Hi, everybody. I have the great pleasure of welcoming everybody tonight. My name is Leah Gruppo, and today I get to introduce one of our amazing endocrinologists, clinical professor of medicine at Stanford, Dr. Marina Basina. Most people know who she is, but I wanted to kind of highlight some of the ways that she gives back to this type 1 diabetes community. She's on the board for Sugar Mamas Beyond Type 1. She's for the Physician Council at JDRF. She's on the clinical leadership for Type 1 Diabetes Exchange. And so those are some of the ways that she gives back. And so without further ado, I just wanted to introduce Dr. Basina for her talk today on Type 1 diabetes and challenges and the use of tech.
Thank you so much, Leah, for introduction, and thank you for allowing me to give a talk today. So it's very exciting for me to be here and to talk about various aspects of type 1 diabetes. So I was, before we started, I was talking about to the panelists that I had a hard time deciding what to exactly to present. And I hope some of the stuff is useful. And I thought that would be probably the good thing to start and to, because this is, I think, our first series. So it would be nice to get started with some basic information, and then we can go into details as well. So I'm going to share my slides. The topic that I kind of chose to talk about is type 1 diabetes challenges, the use of technology, and some miscellaneous information. So here's the agenda for my talk. It's I will start with insulin injection rules, which is kind of simple, but not that so simple. So we'll talk about some of the challenges and some of the recommendations and guidelines. And it sounds very easy and intuitive, but well, I'll show you some information that that is, I think, the most important part of the care. We'll talk about what we have now for technology and what's coming in future. We'll talk about some tips on basal bolus insulin adjustment, when and how to review your own data between the clinic visits, which I think also is one of the most important questions and topics. How to utilize the arrows on CGM or continuous glucose monitoring device, how to make pump adjustments using some formulas that we usually use, and with some summary and conclusions. So the type 1 diabetes prevalence is growing. And although we consider this condition as a condition of children, but 85% of the individuals who have type 1 diabetes are adults, because the kids are growing and going into the adulthood. So 1.4 million adults over the age of 20 or older, or 5.2% of all US adults have been diagnosed with diabetes. And the incidence is actually rising, and we see 21% increase in the prevalence between 2001 and 2008 in youth under the age of 20, and even in older population we see as well. So it's predicted that by 2050, we will have 5 million people in the United States diagnosed with type 1 diabetes. So before we go into further presentation, I will ask Amy to do some poll for some questions. So the first question is just for me to get an idea of what kind of devices you are using for your insulin mode delivery. Is it multiple daily injections, insulin pump without closed loop? Would it be Omnipod, Medtronic, or Tandem? Would it be insulin pump with a closed loop? Is it Tandem Control IQ, Medtronic 670G, or loop, or open APS, or DIY? Yeah, if you can open the polls and please vote. So 40% on multiple daily injections, 10% on insulin pump, and for Omnipod, 10% on Medtronic closed loop, 10% on Tandem, 30% on Tandem closed loop, and no one on Medtronic 670G, and no one is on the loop. Okay, great. And can we have the second poll? So the second question is, how many times do you upload and review your own data in between the doctor's visit? or your either doctor visits or diabetes educator appointments. Are you doing it every 2 to 3 months? Are you doing it monthly, every couple of weeks when you just feel that something is going wrong, or never? Okay, that is really great. So third of the people do upload and look at the data every 2 to 3 months. That's excellent. 20% every couple of weeks. That's very impressive. And 20% was something in wrong, and third, never. So it's kind of very distribution similar with the numbers across the board. So it's not that difficult not to get overwhelmed. And as you can see, there's so many different factors that are can affect blood sugars. And here on that list from Diatribe, you can see only 42 different points, but I'm sure we can find a lot more than that. But I really believe that one of the most important factors in this list is the injection technique and injection in the possible scar tissue, and trying to get to keep those injection sites healthy, because that's the most important part of the management, because we have wonderful technology now. We have different closed loop. We have the more closed loops are coming, but they're all going to work only if the sites are good. So if the sites are not good, then we are not able to utilize any of that technology. So initially, when I was trying to look at this issue, like injection techniques, I thought that it probably will be like 1 or 2 papers, very brief. But it's actually interesting that there were the whole international forums on how to take insulin injections correctly and how to rotate the sites correctly. So it was a feeder a forum that had 15,000 attendees, and it was in Rome in 2015. So recommendations were published from that forum, recommendations and the guidelines on the technique. So that was very impressive. So what the recommendations were is that the insulin absorption is affecting significantly and gives us all the variability in the glucose measurements after the injection. So our skin thickness about only 2 to 2.5 millimeters, and it's fairly standard. Doesn't matter what the body weight is and what kind of body habitus do we have. So when you use the needle or choose the needle for those who are on multiple daily injections, and look like we have quite a significant number of participants who are using the MDI. So use the smallest needle, because the smallest needle reliably goes through the skin and enters the subcutaneous tissue and delivers you the insulin into the subcutaneous tissue. It is safest to use for children and adults of all ages and all BMI, regardless of the BMI. Inject with 90-degree angle. So when you use that short needle, you don't have to pinch. You can just go straight without pinching, because you will get into the subcutaneous tissue. For children, pinching is needed, may be needed. If a child is less than 6 years old and very thin, then you can lift the skin, but be careful to lift the skin, not to lift the underlying tissues with the skin. But some use 4 millimeters. If you use a 4 millimeter needle, you don't necessarily have to lift the skin. Now, this is if we're using the pen needles. If we're using the syringes, the shortest needle is 6 millimeters. So use oblique injection if the individual is with the angled injection if the individual is thin. And try not to use syringes for someone who is BMI less than 19. So where the site of the injection is really affecting the absorption. So there have been studies looking at the time of onset and duration of insulin depending on the time on the place of the absorption. And as you can see, that abdomen, you can reach the peak faster and the duration is shorter. But if you use on deltoid, which is the arm or femoral into the thigh, you can see that the duration is a little longer. The peak is slower and a little bit lower, So always kind of think what you want to be this injection for. Do you want it to act really fast, or do you want maybe it's a higher fat meal or something that you would need to actually the delayed absorption of this injection? So it also depends on the physical activity. Obviously, if you put it in the leg and then start running, so the absorption may be faster, but in general, that's what it's affecting. So what we're trying to avoid is the formation of those lipohypertrophy. So again, this is the most important one, and we see this very commonly in the clinic. And it is very common, again, it affecting 53 to 70% of the patients. And it causes erratic and unpredictable insulin absorption and leads to significant glycemic variability and hyperglycemia or unexplained hypoglycemia. So if you see the numbers going up and down and you cannot explain it, and you would say, yesterday I did exactly the same and my numbers were perfect, and today I did it and the numbers are all over the place. So this could be one of the factors that could be affecting the blood sugar control. So reduced insulin absorption up to 25%. And if you switch to a different site, to the site that has not been used before or used not minimally, that significantly increases the risk of hypoglycemia, and the dose lowering may be needed. So factors affecting lipohypertrophy: improper site rotation, repeated trauma to the same site. One of the most important one is reusing the needle. So I know that a lot of people use it just because it's easier and it's saving the resources, but it's important to reuse the needle. So the needle has some old blood products. So when you introduce it back into the tissue, there will be a little bit inflammation around that needle. And if you repeatedly it's done, that causes more inflammation and more scar tissue formation. So it had been shown that unexplained hypoglycemia happens in 39% of the patients with lipohypertrophy and 6% of patients without lipohypertrophy. Glycemic variability also significantly higher in patients with lipohypertrophy comparing to without. And when the surveys were done to the patients reported that only a third of the patients actually were asked at the clinic to look at their sites and to check their sites. And 28% could not remember that their sites ever been checked in clinic. So it's important to give a message to healthcare provider and to remind us, if we didn't ask you about this during the clinic visit, that it is important for us to look at the sites and for you as well when you are doing your shots. So those are recommendations for rotation. So you would divide all the areas of the abdomen, arm, and leg, and you would use one quadrant first. So you would use one area and you keep rotating in one side, and then you move to the other, and then to the different quadrant. For example, this is the abdomen. So you only need about one finger width in between injections or in between the infusion sets. So again, to take home point, two main factors in the development of the scar tissue: it's improper site rotation and reuse of the needle. So again, I think it's one of the most important factors in the good control, because of that's the absorption more consistent to get insulin absorption. So what are the other issues with the insulin infusion sets? Occlusions do not always trigger the alarm. So you may have high blood sugar and not hearing the alarm of the pump. So always check the infusion set or take the shot and see if the shot works when bolus was not working before. So again, as I mentioned, success of the closed loop depends on reliable insulin infusion, and delivery interruption for 4 to 8 hours may lead to ketoacidosis. So blood sugar increases approximately 1 to 2 milligrams per deciliter per minute when insulin delivery is interrupted. So the following questions might be useful in determining the failure of the infusion set. How many days to wear the insulin infusion set? Are there any unexplained hyperglycemia instances? Where do you wear your infusion set, and does it look differently than the rest of the body? Do you notice any scar tissue, any bumps, or any fatty buildup? And do correction boluses if you're not sure about the site. do some highs only when you change your infusion set. Does that only happen when you change your infusion set? And just briefly show you that some of the issues with the infusion set that can be happening with the cannula tip obstruction due to the scar tissue or kinking of the cannula, or fibrosis of the cannula at the side of the cannula, or insulin precipitation in the cannula. So to take home points, again, be sure to rotate the site, use whichever figure you want to use. Infusion site change every 72 hours. Is if kinking occurs, then use shorter cannula or use the oblique or steel cannula. And if there are frequent silent occlusion or unexplained hyperglycemia, just try to use different sites. And if 2 corrective boluses do not lower the blood sugar, then don't test this site anymore. Just use the pen or syringe and change the site. So we're moving to technology. So technology, what is current and what is coming in future. So Tandem X2. So I think about 30% of you are using Tandem and with Control-IQ or without the Control-IQ. So this is the hybrid closed loop pump, which is very popular and works really, really well. And a lot of patients are really happy with this pump. So the pump is small for those of you who have not seen it. It's a touch screen pump. It's a rechargeable. There's no battery. It uses CGM data from Dexcom for titration of the basal rate. And when CGM is predicted to be less than 80 or currently less than 70, the pump will shut off, as you can see on this picture, and insulin delivery is stopped. And it resumed when blood sugar in range or rising. It does have the fixed target, which is 110, or this mathematical target of 112.5. And if the numbers are between 112 and 160, it uses current profile, what is programmed. It also delivers the auto correction if Dexcom predicts that glucose is rising and will be over 180. And it triggers the bolus that is a 60% of the calculated corrected bolus, and that's delivered every hour. And you can still use, a lot of patients don't like the Medtronic pump because they cannot use the extended bolus. So you can use extended bolus with Control-IQ up to and extended up to 2 hours if you're eating higher fat meal or not sure how much you're going to eat. So it does have a sleep mode, and a sleep mode range between 112 and 120. It should be, the target should be reached within 5 hours. And you can choose your different sleep times and set your different sleep times on the weekends or the weekdays. And again, it has the exercise target, 140 to 160. So the blood sugar target, the lower one would be aiming to 140, not to 110 or 112 if you want your blood sugars to stay on a higher side during the exercise. And again, it will stop the basal, not at 70, but at 80. So Tandem news, Tandem is coming with a sports pump when we don't have an announcement of the date. But as you see, this pump is smaller, so it will have the you can see there is a roar outside. It will only have those emergency buttons on the pump itself. It would be connecting with the T-Connect app for bolusing through the mobile app. It's about half of the size of the current pump, and it will be submitted to FDA approval maybe early next year, but not clear when it's going to come out yet. And it has more personalized Control-IQ settings. For Medtronic or MiniMed, this is the current system. So it's a hybrid closed loop insulin pump, the very first one that was approved by FDA. So it has this auto mode when this blue shielding is on. So the pump is adjusting the basal rate on its own. So it does not use the basal rate that is programmed on the pump. So it used the total daily dose for the past 4 to 5 days to sort of adjust mean number. It uses the mean dose for the past 5 days to calculate how much insulin is needed for both correction and for the basal adjustment. So for this pump particularly, we can change the carb ratio, and we can change the active insulin time. The rest is pretty much calculated by the pump, by the algorithm. It automatically adjusts the basal every 5 minutes with the blood sugar levels all day at night. So Medtronic 780G should be coming out. So new sensor predicted to be this Zeus, which is actually not going to be coming right away with the 780. So this one will be only with one calibration on the first day of wear, and it's also going to be 7-day wear for future. So the goal for this pump is to have time in range over 80% for the majority of the patients. But Zeus has not been yet approved by FDA. So the first version of 780 will be still coming with the current Guardian 3 sensor. So it will also give automatic correction every 5 minutes, and it will be using adjustment for the missed insulin boluses more aggressively than current one. There will be 2 targets offered. You can choose either 100 or 120. And there will be adjustable insulin duration times, and it will be a Bluetooth data sharing that you can share with your significant others, and also remote monitoring. So the current version 770G was approved for kids 2 years or older. So Dexcom 7, everyone is excited and waiting for it to come out. So this will be all in one transmitter and sensor all together in one piece. It will be fully disposable. It will be also for possibly 14-day wear, although I've heard different things about it. It will have no calibration as the current one. It will be 60% thinner than the current one, and it would be the thinnest one on the market. And the warm up will be half an hour comparing to the current one that is 2 hours. So there will be possibly different versions of sensor for type 1 and type 2 diabetes. So Libre 3, so everyone is excited in Europe because it's already being used in Europe. It's been approved, but not here in the United States. So you can see that it's 70% smaller than the current one. There would be no need for scanning. It would be real time, and it would be generation of glucose every minute, and data would be displayed in the app. So there will be optional alerts and alarms for highs and lows. And the accuracy is about 9.2%. So for the Dexcom G7 to compare, so the lower number, the more accurate the device. So for G7, the predicted MIRD would be 8.5%. So they're pretty close to each other when it comes out. So hopefully we'll have very exciting news coming soon for the Omnipod 5 or Horizon, which was on the trials. So this is the Omnipod. So this is the pod itself will be connecting with the Dexcom. And it would be a closed loop system, which is going to be possibly coming out with the app on the Android phone, but not through the iPhone yet for the mobile insulin delivery through the mobile app. So there will be adjustable target, 110 to 150, and it will be feature of hyperprotect. What that means is that the system would be delivering half of the dose when the hyperprotect feature is on to protect from hypoglycemia. So far, so we are doing inpatient study closed loop currently with the Omnipod 5 using that system. And so far, the experience has been very, very good. So we'll see when it comes out. So some practical tips on the basal and bolus ratios. Check when you are doing your personal download and when you are looking at your own data retrospectively check what is your percentage of basal delivery versus the bolus delivery. So for puberty and prior to puberty, the basal dose should be lower because usually the content of the meals is higher in carbohydrates. Of the pre-puberty, the counter-regulatory hormones or stress hormones are lower, and kids could be still in the honeymoon phase. So the basal percentage is only 30 to 40%. For puberty, there's actually the dose is usually higher, could be up to 1.5 times higher comparing to the even adult use. And their growth hormone is up, cortisol levels are up, which are all raising the blood sugars. So use higher basal percentage. For adults, 45 to 60%, depending on the meal intake, depending on the carbohydrates intake in the meal. And for elderly, again, decreasing the basal because of the higher chance of hypoglycemia. So for correction, bolus, or use of the correction. So we hear this all the time in the clinic, oh, my correction dose is not enough because it doesn't allow me to correct. So if it doesn't allow you to correct, then something was not bolused in the beginning correctly. So ideally, we don't want to use frequent correction. So this is like a retrospective correction. So we want prospectively to try to control the blood glucose. So the target for correction bolus is to be not higher than 8 to 9%. And if higher, then, and lows are not an issue, then move that correction dose to the either basal or insulin carb ratio change. So I put here, and I don't have to go through the details of this, but for the insulin pump comparison, what will be adjustable, what won't be adjustable in different pumps. So again, Medtronic pump targets are adjustable only for current, you can use the target of 150 up to 12 hours for exercise. And you can only change active insulin time and carb ratio. So the rest is determined by the algorithm. For tandem pump, the targets could be 110 to 120 for sleep, 140 to 160 for exercise, 110 to 160 for the regular day activity. So changes could be made as in carb ratio, basal rates, and correction factor. For the Omnipod, for the Omnipod Dash, the current one, you can change it because it's now not integrated with the Dexcom. So anything you can change in this pump because it's separate from the Dexcom and it's not a closed loop system yet. Now, how do you, if you do review your data, which is great, I'm so happy to see that a lot of you are doing this. This is, I think, excellent. So how do you make sense of this data and understand this data? So there is a delay between what we see on the Dexcom and between what's happening in the blood. So it's a lag time between interstitial fluid, which is where the sensor is measuring the glucose interstitial fluid, and what's measuring in the blood. It takes time for that reaction in the sensor to occur, to send that data to the transmitter and for the transmitter to the receiver, which could be either the pump or your phone app or whichever device you're using for the receiver. So due to that, so if the blood sugar especially is changing pretty frequently or pretty rapidly, that's the number may not be exactly the same and won't be the same as the number on your finger stick. So what are the keys to success is to look at those trends more often. They work with those lag times. It's important to remember about those lag times. To know about the food lags of the insulin lags, the sensor lag. So for the insulin to be delivered before the meal, if you're on the insulin pump, I will show that data, the speed of the insulin delivery. And not afraid to experiment and don't aim for perfection because that's no one is perfect, and we can't have everything perfect in our life. So when to download? You decide when you're, and maybe try in those kind of life events. So if you're just feeling frustrated that something is not going right and why the blood sugars are so variable, that you're doing something, you're doing everything you can, but the numbers just don't make sense. Just review it and look at it retrospectively. If there are some lifestyle changes or the changes in the medications, if you're going through some New Year's resolutions, or to decide I'm doing so well, why is my A1C so high? Where I'm missing those high or spikes that are showing up in the A1C. Preparation for any of the life events, marriage, pregnancy, and if you just want to make changes and be perfect. So this is an example of what we see in clinic of the ambulatory glucose profile from Libre and from the Dexcom. And for the recommendations for the glucose to stay for the green bar to be in range 70% or higher, and the range is 70 to 180. So those sensors work well if we use them. So we're at least 70% of the time or more. And we use GMI or glucose manager indicator as a kind of reflection or prediction of what A1C will be, although if the A1C is reflecting highs and lows, right? So the time in range is more reflecting what's real time, what's a time in range is. So try to see, don't focus on the individual numbers. So those individual numbers can be frustrating, but those numbers changing very often, and don't look at those numbers. Try to see it, look at the patterns. Is there some pattern on this picture? Yes, higher in the evening and then drop and then going back up during the day. Or if there is no pattern like in this picture. So the retrospective kind of review will give you some more comprehensive view of where the spikes are, what are the postprandial spikes, what are your nocturnal patterns, and how to determine and to adjust the dose. So before reviewing the data, it's useful to keep some records if you decide to make it more useful. So keep the records for 1 to 2 weeks before uploading, because then you can always go back and see, oh, this is what happened, and that's why this day my blood sugars were either high or low. So timing consent of the meal, especially if that was something unusual. Duration and nature of exercise that Desi talked to us about last week. Insulin doses. Was there some unusual dose that was administered with the injections that would be useful for me to review looking now at my retrospective review of my Dexcom? Some of the events that happened, was I eating out on that day in this my favorite restaurant, and what happened with my blood sugar after that? Was there some kind of specific stress or menstrual period? Was there basal testing? If you want to do some basal testing, you can look at, you can write down that day when you had it done. So again, as we said, identifying the patterns is the most important. And the most important thing to start with is to stop the lows. Because if you start taking care of the highs first, you will get with more lows. So try to analyze, what are those highs? What are those lows from? Probably from overcorrection. So if we try not to overcorrect and just take time for that blood sugar to come down, so you won't get the low, and subsequently with less lows, you would have less of overcorrection of highs. So that creating this ups and downs in the blood glucose levels. So again, stopping the lows would be number one, and looking at your basal bolus ratio. So if you're having highs and then a lot of lows, is it carb ratio is not correct, and then you have to correct many times after that and going low? Are you concerned of taking too much insulin because your basal rate is too high and does not allow you to bolus for the meals? So all those questions would be asked when you review your data. So for the closed loop issues, so the closed loops are have different algorithms. And I did not mention the algorithms here just because of the time, but so those are all the components of the closed loop system. So closed loop system works well with pre-bolusing for the meals. So a lot of the times we would say do like bolus right before the meal. So realize if you're bolusing right before the meals, the bolus delivery is quite slow. So the standard delivery for a Medtronic pump is 1.2 units per minute. For Omnipod, the same thing, and even a little slower for Tandem. So if you are taking a bolus of 15 units, it may take the whole 10 minutes for that bolus to be delivered. And then another 15 minutes for the insulin to start working. So you're losing that already 25 minutes when the blood sugars already started spiking, right? So, and what is liver doing at that time? It's putting out more glucose because that insulin to get to the liver and suppressing that glucose production in the liver may take an hour and a half. So during all that time, the blood sugar started going up, the insulin for the closed loop going up, plus you might be giving yourself, so what we sometimes call fake boluses, because the numbers don't come down and they keep going up, and the Dexcom is screaming, and that ended up with the low afterwards. So it's useful to look at those errors on different sensor devices. And because of the closed loop, you cannot put the wrong blood sugar reading in because otherwise it's going to kind of confuse the sensor. What you can do is to put extra carbs as an anticipated glucose rise. To give you an example, so if the Dexcom shows you that you are 2 errors going up before the meal, that means that glucose rate change is 3 milligram per deciliter per minute. So that predicted in 30 minutes, you will be 3 times 30, you would be 90 points higher. If your insulin correction factor about 1 to 30, so you would need 3 units to change to get to prevent that, right? Because if you're already going up and in 30 minutes, you will be 90 points higher. So you would need 3 units. Let's say and I know it's a little complicated, and I'm happy to go over it again, but I've been using it a lot in patients and it actually works quite well. So if you think about if your carb ratio is 1 to 10, to get to this 3 units, you need to enter 30 extra grams. Right. So if you're concerned about entering those 30 extra grams, which is totally understandable, start with 10 or 15 grams extra when you are going up. So just to see, just to get this trust in those formulas and see how they work. So the other way around, if you're going down. So if you're going down, for example, on Dexcom, 1 arrow down, you're going down by about 2 milligram per deciliter per minute. So that means it's going to be 60 points lower within 30 minutes. So put in less carbs because you're already going down and you don't want to drop soon after that bolus. So this is just another view with different sensors. And I think the slides will be shared so you can see which different sensors, how they, what those arrows mean on those sensors. So how to assess postprandial spikes? So you can see the different tracings and you can see what's wrong here. So here the bolus was given and it worked really well. So it was given on time. But here the bolus, the blood sugar started going up, and here's the bolus comes when the blood sugar is high. And what happened after that? So the insulin duration is longer than the food duration and the blood sugar drops. So the kind of the same thing as in this graph. This bolus is given right at the onset of the meal. So this was some kind of very fast acting carbs, spike really quickly. So the insulin duration was still, the insulin half-life or the insulin was still there, but the blood sugars dropped. Again, what is the solution? For the higher the carb content in the meal, the earlier the postprandial spikes, and the insulin is given right before the meal in those scenarios. So try to take insulin before the meal. So 15, 20 minutes before the meal. So some useful formulas to use for the dose adjustment that's we usually use in the clinic to see if those numbers make sense. So for the carb ratio, you can use the what we call fudge factor, 350 to 450 divided by total daily dose. And it should be adjusted based on low-fat meals with known carb content and acceptable 2-hour postprandial rise is approximately 60 milligram per deciliter above the preprandial. So if it's over that, then adjust the carb ratio by 10-20% increments based on those postprandial spikes. And again, don't overcorrect it right away because this one spike is not going to cause any complications, but try to think about for future how to make those adjustments and how to correct that for future. For correction or insulin sensitivity factor, use approximately 1700. You can use anywhere from 1500 to 1800 fudge factor divided by total daily dose. I would say if you use 1700, that could be standard use for everyone. That's for average person divided by total daily dose. So for example, if your total daily dose is 50, so 1700 divided by 50, right? So that would be about 30 or a little bit less points. So if sensitivity factor is within, so if you use the correction and your blood sugar is within 30 points of the target within the 2 hours after the correction, then you did it right. So if it still stays higher or drops too much, then you can adjust by 10-20% increments for your own settings. So this is using, again, right between our visits, clinic visits, so you can try to do it yourself. So for summary and recommendations, so prepare yourself to view the data, choose the right time to do it. No one is perfect. So when you review the data, anticipate seeing highs and lows and don't get frustrated. This is what life is about. So there are ups and downs from our everyday life. Review the patterns. Don't focus on the individual numbers. Assess CGM in conjunction with the insulin data. So a lot of the times we would have in the clinic only data from CGM, we would say it's so hard to make sense of it because we don't see how much insulin and when it was delivered. Target hypoglycemia first, as we discussed, because usually lows trigger highs and then highs triggers lows. Like one of our nurses in clinic, she usually says, oh, this is the pattern, low to high, high to low. So if you try to correct hypoglycemia first, you will have fewer highs and then subsequently fewer lows with that as well. If there's no pattern, just start from scratch or contact your private provider to help with those recommendations, to have someone else as a new look. Because sometimes when you get stuck and you're thinking that doesn't make any sense, I'm not sure what's going on. So have someone else look at it and see what someone else suggested, because sometimes it would be much, with the new kind of another set of eyes would be easier to look at. Review your total daily dose, percent of the basal and prandial, correlation with the carb intake. And don't make a lot of changes. Make small changes at one time. Make only 1 to 2 change, and then don't change daily. Don't change several times a day. Just wait for 1 to 2 weeks to see how that works. Because one day can be it may not be working, but the next day it's actually, and for the next several days, it can be working perfectly. Again, think about correction factor as a retrospective correction. So the lower the correction factor, the same thing, for example, in the closed loop systems on Tandem, we see what percentage of correction bolus. So the lower, the better, because that means that everything is done perfectly and system does not need to use those corrections. And again, be realistic, have low expectations when you start, and then accept that it is a learning curve and no one is perfect and everyone is very different. So it could be something that works for one person may not work for you. Use situational thinking. What has been done recently? What's current? What's coming up? Choose what you consider actionable. So I can change this, make this one change in my life or 2 change to get my numbers a little bit more in the time and range. And is it worth doing something about it, about this change that can make you feel better? Be patient, and then you will all get perfect control. So it is a full-time job that you are doing, and we're all admiring what you are doing and what you're going through. So definitely do not punish yourself for anything. And it's just the day-to-day learning and the day-to-day learning curve for all of us. And I'm happy to take questions.
Great. Thank you so much, Dr. Basina. I learn stuff every time I get to listen to your talk. So we have some questions already. So this participant's asking about the Omnipod bolus rate. He thinks it seems low. He's measured it at 2.5 units per minute. So what he's asking is that is the dash a lot slower than the original Omnipod?
I think they're the same. So so on the dash, you cannot change the speed of the delivery. So on Medtronic insulin pump, you can change it from, there's a standard, and I think it's called quick or high speed or something. So you can change and do the higher speed of the delivery of faster delivery for a Medtronic pump, but you cannot do it for a dash or for a tandem pump. So those are standardized. So I'm not sure how you measured it, but this is what's reported. This is what I found online.
Great. And I definitely invite everybody to put their questions in the Q&A section, and we can definitely go through and answer them with our remaining 10 minutes. So there is just one other question that we have right now, and they're asking if there's actually, Stanford has a standing thought on the open SW loop form for the closed loop control. I'm not really sure how, but that's the question, Dr. Basina.
Can you clarify the question? Does it have looping, meaning the DIY loop? Or
I think they're talking about the DIY loop, which...
So we don't have a Stanford forum. So there are a lot of Facebook groups and a lot of the, so they are different websites, and there is a great website. It's called Loop and Learn. I don't know if you already are on that one. Loopdocs.com is a great one. Yep. So that's so Loopdocs, and also the Loop and Learn is more for some more simplified versions. And they do have a lot of seminars. So we just did one seminar for Loop and Learn with one of my GI colleagues for different GI issues in type 1 diabetes. So I think it was recorded, and they did post on their website. So if you're interested in any of that. But yes, Loopdocs is good, and Loop and Learn is a good website as well.
Great. Here's another question. Dr. Basina, what do you think about the Afrezza inhalable insulin? This participant is saying it seems very fast acting.
Yeah, that's a great question. I actually was debating whether I should put the slides on the Afrezza insulin, but then I didn't think that I would have enough time. Yeah, so it's a great insulin that can be used for, some patients use it for constant use for the boluses instead of the boluses. Some patients use it for certain circumstances. For example, if you're eating some high carb meal, or if you need this fast blood sugar correction and you are concerned going to sleep with this high blood sugar, and you want fast correction, but you don't want that lingering bolus for overnight. So that's a good way of using the Afrezza. So it's a little bit tricky when to use it with the loop or using with the closed loop system, because the closed loop system controlling you based on your total daily dose, right? So when you are using frequently the Afrezza, you get underestimation of what your total daily dose is, and you would be not as aggressively corrected by the closed loop system. So there are pros and cons. I've heard that there are some algorithms that coming out with possibly entering that data information into the algorithm and kind of notifying the closed loop that, especially for the DIY, community for the loops and for open APS that I am doing this aphrasa, and the pump will keep it in mind. But so especially it's harder to do for the ones who are using the Omnipod, because you cannot disconnect and you cannot use it. You cannot sort of give the what we call the air shot bolus for that. Yeah, so I agree with Jesse that it doesn't have the granular dosing, but because it's so fast, it's actually easy to use for those just fast corrections. So a lot of the patients will do, so when you are seeing your Dexcom started to come up and you don't want it to go up, so you just take either a smaller dose, because you can take in another hour or 2 hours, you can take another dose because it will be gone. The half-life is very short. And that is true. You cannot, so it comes only in 3 doses. So it's 4 units, 8 units, and 12 units. And those are not the equal to injectable units. So those are called aphrasa units. So that they about 1.5 to 2 times higher than the injectable equivalent. So 4 units cartridge will be about 2 units, 2.5 units of the injectable. And it's very important to inhale it correctly. So if you don't inhale it correctly, then it's not going to work well because you don't get it to where it's supposed to be. But yes, it's really, really, really great. It's very good for some patients who are having issues with the injection sites and just want to take a break from the injections, and they want to use some, just give your sites a little break and to use some of this inhaled insulin. So it's not that easy to approve, but we are able to get it approved in most of the cases.
Great. We have another question too. Is there a significant difference between Fias and Lyumjev absorption profiles? I might not be saying that right, Dr. Basina.
Yeah, so it's very individualized. So Lyumjev just came out and just got approved for the use of the insulin pump. So when Fias came out, there were a lot of debates where it has a little bit more sticking to the tubing compared to the Novolog insulin. And some patients were happy with the Fias, but per the studies, the dose in about 50% of the patients, the dose requirements were going up by about 10-15% on the Fias compared to Novolog. So when we did our study, and it was kind of interesting because we did a double blinded. So neither us nor the patients knew what kind of insulin we were using. So we were handing the patient, I would say it was a little nerve-wracking study because I was giving the patient the bottle that has nothing on it. So it could have been just the water. And I was a little concerned, like, what is that? But everyone was safe, but there was no difference pretty much. So it was, the numbers were very similar to Novolog and Fias. For the Lyumjev, I've heard very good. I don't think there was any of the direct head-to-head comparison trials with the pump. I have not seen that, but from just clinic experience, I see that some people are very happy with it. And about 30% of patients do experience some burning at the injection. So it may or may not go away, but some patients try it and they cannot use it because of that burning sensation. But comparing Lyumjev and Fias, theoretically, Lyumjev may be a few minutes faster. It shouldn't be a lot of difference, but a few minutes faster is that's what. But there was no head-to-head trial comparison. This is just what had been reported from the trials.
And Dr. Basina, just one thing to mention too with, I know Lyumjev, whether it's Lyumjev, there's a few different pronunciations of the actual insulin, but there are a few studies that are being done, and Stanford will likely be a site for one of the upcoming studies as well. So that's been really excited to just be able to test new insulin formulations. But just like you said, whether it's going to be insulin like Fias compared to Lyumjev or Lyumjev, there will be upcoming studies, absolutely. If not done at Stanford, there are definitely other sites looking at this as well.
Yeah, no, absolutely. I'm sure there will be different studies.
Great. Well, I don't see any more questions. So I think this is a great time to close. So thank you so much, Dr. Basina, for this very great talk. And Definitely learned a lot. So, and thank you, Desi, also for helping. So next Wednesday, the 17th, we have another talk. I'm going to talk about nutrition and macronutrients and carb counting and sort of some of those meals that just seem to be hard to bolus for. So I hope that you can all join for that. And so excited about this type 1 diabetes series. So thank you all for joining.
Great. Thank you so much for all your being here on this late evening, and have a wonderful night. Thank you.
Hi, everyone.